Hi friends, I am Dr. B.B. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.in and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary, for the medical knowledge to general people and for reference to medicos. Today I am going to discuss about the rare external hernia. Interparietal hernia, or otherwise called interstitial hernia. The interparietal hernia has a sac and it passes in between the layers of the anterior abdominal wall. The sac may be associated with or communicate with the sac of a concomitant inguinal or femoral hernia. If it is not identified, may cause misdiagnosis and mismanagement. Types: properitoneal hernia. The sac takes the form of a diverticulum from a femoral or inguinal hernia. These can be quite different from the peritoneal hernia. Properitoneal hernia. Intermuscular hernia. In case of intramuscular hernia, the sac passes between the muscle layers of anterior abdominal wall between the external oblique and internal oblique muscles. The sac is always bilocular and is associated with inguinal hernia. Inguino-superficial hernia. The sac expands beneath the superficial fascia of abdominal wall of thigh. It may be congenital or acquired due to wearing of truss or blocking of superficial inguinal ring by an incompletely descended testis, hydrocele of the cord, or hydrocele of the canal of Nook. The inguino-superficial type is usually associated with an incompletely descended testis. Clinical features: the occurrence is more in males than in females. Majority of patients present with intestinal obstruction due to obstruction of or strangulation of hernia. In these circumferences, the cause of the obstruction should be apparent. In the intermuscular and inguino-superficial varieties, but in the proparietal variety, as no swelling is likely to be apparent, delay in diagnosis occur and consequently the mortality is high. Treatment: operation is a must because of intestinal obstruction. In all cases of inguinal and femoral hernia, a finger should be introduced into the sac to detect an unsuspected intraparietal locus. Spigelian hernia. Spigelian hernia is a type of interparietal hernia. The spigelian fascia is the aponeurosis intervening between the muscular part of the transversus muscle and the rectus sheath. A spigelian hernia is the one occurring through the spigelian fascia and usually at the level of the arcuate line. The fundus of the sac clothed by extraperitoneal fat may lie beneath the internal oblique muscle, where it is impalpable. More often it advances through that muscle and spreads out like a mushroom between the external and internal obliques and gives rise to a more evident swelling. Men and women are equally affected and the patient is corpulent and over 50 years of age. Usually a soft reducible mass will be encountered lateral to the rectus muscle and below the umbilicus. After reduction, a small oval defect can often be felt, and because of the rigid fascia surrounding its neck, strangulation may occur. In an obese female, to differentiate a strangulated spigelian hernia from a twisted ovarian cyst or a Hematoma due to tearing of the inferior epigastric artery may be impossible. Treatment. Surgery is preferred as the repair is easy. The external oblique aponeurosis is split. The sac is isolated, dealing with any contents and ligating and excising it. The transversus, internal oblique and external oblique muscles are approximated in layers. Lumbar hernia. The lumbar hernia again exit through the inferior lumbar triangle or petit triangle of Petit, bounded below by the iliac crest, laterally by the external oblique and medially by the latissimus dorsum. In some cases may come through the superior lumbar triangle, which is bounded by the 12th rib above, medially by the sacrospinalis and laterally by the posterior border of the internal oblique. An extensive incisional lumbar hernia sometimes follows an operation upon infected kidney with the post-operative infection of the wound. It is to be differentiated from the cold abscess, phantom hernia due to the paralysis of the local muscles. It occurs due to the interference with the nerve supply of affected muscle like poliomyelitis. Treatment. A primary lumbar hernia, as is small, need not require extensive operation for repair. Post-operative lumbar hernia is large and the defect is impossible to repair unless facial flaps are used. If necessary, the area can be reinforced still further, stitching in place a piece of tantalum gauze or Dacron mesh. Perineal hernia. It is the hernia through the pelvic floor. It is common after excision of the rectum. A reducible swelling appears lateral to the anus. Types. Anterolateral perineal hernia. It occurs in women, passes through an opening anterior to the transversus perineal muscle to enter the labium majus. It is more frequent. Posterior lateral perineal hernia. It passes through the levator ani to enter the ischiorectal fossa. It may rarely strangulate. Treatment. A combined operation is generally satisfactory. The hernia is exposed by an incision over the swelling. The sac is opened and its contents are reduced. The sac is cleared from the surrounding structures and the wound is closed. With the patient in semi-Trendelenburg position, the abdomen is opened and the mouth of the sac is exposed. The sac is inverted, ligated and excised, and the pelvic floor is repaired. Median sliding parietal hernia. It is a complete prolapse of the rectum. Post-operative hernia through a perineal scar. It may occur after excision of the rectum. It may occur at any time after the operation after 1 year. Many symptomatic hernia of this kind are overlooked as the patient is not examined in the erect posture. When the symptoms are present, they include pain on sitting, a feeling of perineal pressure while walking, and sometimes perineal swelling is seen. Treatment. It can be repaired by excising the scar, reducing the contents of the sac into the peritoneal cavity, closing the opening in the peritoneum and approximating the edges of the levator ani. If sufficient of this muscle can be identified. A flap of the gluteus maximus muscle and fascia are freed and sutured in such a way to form a single sling to support the closed perineum. Obturator hernia. It is common in women over the age of 60 years. It passes through the obturator canal. The swelling is overlooked as it is covered by pectineus muscle. It seldom causes a definite swelling in scraps, scrapos triangle, but if the limb is flexed, abducted, and sometimes the hernia is more apparent. When the leg is kept in semi-flexed position, the movement increases pain. In a majority of strangulated obturator hernia, pain is referred along the obturator nerve by its geniculate branch to the knee. In vaginal or rectal, the hernia sometimes felt as a tender swelling in the region of the obturator foramen. Obturator hernia presents themselves have usually undergo strangulation. Treatment. On the side of the lesion, lower laparotomy is to be performed. After confirming the diagnosis, full Trendelenburg position is adopted. The constricting agent is the obturator fascia. Taking every precaution to avoid spilling of infected fluid from the hernial sac into the peritoneal cavity, this fascia can be stretched to allow reduction by inserting suitable forceps like cholecystectomy forceps through the gap in the fascia and opening the blades with care. If the incision of the fascia is required, it is made parallel to the obturator vessels and nerve. The contents of the sac are dealt with secundum artem. The broad ligament is stitched over the opening to prevent recurrence. The abdominal wall is closed. Gluteal and sciatic hernia. A gluteal hernia passes through the greater sciatic foramen, either above or below the piriformis. A sciatic hernia passes through the lesser sciatic foramen. It is to be differentiated from the lipoma, fibroma, fibrosarcoma below the gluteus maximus, tuberculous abscess, and the gluteus aneurysm. All doubtful swellings in this position are explored by operation. The swelling is approached by splitting the fibers of gluteus maximus. After isolating the hernial sac, opening it and dealing appropriately with any contents, the neck of the sac is ligated and the sac is excised. The flap of fascia raised from the covering of the piriformis muscle is used to close the opening through which the hernia extruded. That's all about the rare external hernia, and in the next video I will discuss about some other diseases. Thank you.